bacteriology, and okay, we'll be covering Streptococci. I can see I'm being recorded, that's fine. So hopefully you're all in. If possible, if you could also write your names and registration number in the chats. I need to collect this for the register. If you have any other innovative way that you take your registration, please let me know. But for now, you could put your name and registration number in the chat. So I'll be uploading my screen shortly. Please confirm that you can see my screen and if you can see it moving.
Yes, we can see it. And it's also moving.
Okay, excellent. And it's also moving. Okay, so let's start. Again, I'm hoping that you're well. I hope I'm clear. And in case of any queries, please just let me know. And I'm hoping that we can make this as interactive as we can. So again, I've introduced the topic, Streptococci, and we are continuing with our series of gram-positive cocci. And at this point, I'm hoping that you've already covered staphylococci. Please let me know, have you covered my colleague? Yes or no?
Yes.
Excellent. So again, this is just a continuation of the cocci series of bacteria. And before we look at the pathogen itself, I'm just trying to give you a general perspective, again, why we are here, where we are thinking about these pathogens. This morning I was preparing a document on priority pathogens. Because we want to, I'm sitting in a meeting where we are thinking of what vaccines can we start making and considering of a priority. And to do that, we have to look at what pathogens are of interest in the world. And when I was skimming through different websites, WHO, the CDC websites, the top 5 priority pathogens in the world are bacterial pathogens. And in addition, bacterial pathogens that are antibiotic resistant. And this made me come across this article titled Deadly Germs, Lost Cures. And this was in the New York Times, where they were just highlighting some of the problems we have with antibiotics. And here they were highlighting our Kenyan community in the slums, particularly Kibera, where I think, and we can personally attest to this, every other shop or every other street shop, there's a pharmacy or a dispensary that dispenses some of these medications. And as you know, some of these medications that need to be prescribed by the relevant authorities are being prescribed or given without any prescription. And this article is just alluding, we are really fueling this antibiotic resistance because of the overuse of antibiotics. It's a big debate at the moment. And also I saw another article written by our very own Dr. Lois Obajo, where she was talking, we have a pandemic within a pandemic. And what does this mean? Yes, we are dealing with SARS-CoV-2, but we are also fueling another pandemic, and that is antibiotic resistance pandemic, where I think you're seeing some people, especially when our peak was high for COVID-19, most people were running to take some antibiotics such as azithromycin, etc., thinking that this can also prevent them from developing more worse symptoms or outcomes with COVID-19. And this article is also just fueling up. We really need first to understand our pathogens. We need to understand what's fueling this antibiotic resistance. And end of the day, how do we prevent it? So Streptococcus is one of the pathogens that's listed as a priority pathogen because it's developed resistance. And I really want us to spend this morning just looking at the species. And before we look at the species, I came across all this article. And in this article, you can see that it was a discussion really looking at pathogens causing most of the morbidity and mortality in our under our children, particularly children under 5. And one of the main pathogens they listed here, you can see in sub-Saharan Africa, of course, the viruses such as influenza, RSV, but Streptococci pneumoniae being one of the main causes of acute respiratory tract infections in children under 5. So we really need to be able to focus, see why we have vaccines, but are they very effective? And if not, what are we doing about it so that we can make sure that child has the appropriate chance to reach 5-year-old without having all this morbidity and mortality that is being recorded over and over again. Just a housekeeping rule though, if your mic is on, please mute. I can hear some background noise, but if you need to ask me anything or question, you can unmute yourself or raise your hand. So there's 1 or 2 people whose mics are on, and that's creating some background noise. So please deal with it. So having such a preamble back to our streptococci, by the end of this lecture, I want us to have the general just to be cognizant of what streptococci is. I've already listed to you is a priority pathogen. We need to understand it. And if we understand it, what cures do we have? What preventative strategies do we have? And for me, I've always advocated vaccines are the way. We've seen vaccines being very successful in eliminating and eradicating various diseases in the world. And I believe even for streptococci, as much as we have antibiotics, effective vaccines will be the way to go. So we'll need to be able to break down this pathogen, the general characteristics, how it's classified, and then within the streptococci family, we need to look at the different pathogenesis of the subspecies. And for us here, we're interested also how do we diagnose, because we really need to be able first to understand the symptoms and then to be able to do appropriate diagnosis so that we can have successful treatment and prevention. And also I will end my lecture just looking at where we are in terms of research, solutions, and discoveries when it comes to streptococci. So let's first look at the first objective of our lecture. What is the general characteristic of streptococci? And one of them, I mean, we are looking at gram-positive cocci. It's a gram-positive cocci, as you can see in this diagram. It mainly appears in chains or in pairs, as you can see again in pairs, but also forms a chain-like morphology. They're quite small in structure, and majority of them are usually capsulated. And by now, I'm sure you're cognizant of the fact why pathogens, particularly bacteria, have capsules. It's part of their virulence factors. If we're together, probably even ask what is virulency, but virulency simply is what makes this pathogen fit enough to colonize a host, and not just colonize, be able to appropriately get nutrients, reproduce, divide, and thrive inside the host. Remember, the host also mounts a very sufficient and efficient immune response to any pathogen. So this pathogen has to have developed or evolved mechanisms to be able to evade the immune system so that you can colonize. So this end of the day is virulency, and it has evolved several factors that helps it evade the immune system, and the capsule is one of them. This is a very popular question that we normally ask in our exams, in our CATs, in our orals. So I really need you to be able to understand virulency, and the capsule is normally one of the major virulent factors because it prevents this pathogen from undergoing phagocytosis. And I believe by this point, you've also done some immunology. So some of these terminologies such as phagocytosis are familiar to you. Another virulent or another characteristic, they're non-motile, meaning they lack the flagella. Flagella is also a virulent factor, which helps the pathogen move from one cell to another. For streptococci, they don't need the flagella, they're non-motile. They use other mechanisms to be able to infect different cells. They do not have any spores, so the bacteria normally need spores. Some bacteria need spores to be able to propagate, to reproduce. This particular one does not need that. They are facultative anaerobes. Again, this should be something familiar to you, anaerobic or aerobic, so they can thrive in environments that either have oxygen or no oxygen. So This is something also you need to be familiar when you get such terminologies. Another terminology or another characteristic of streptococci, they're fastidious, meaning they are very specific in terms of what nutrients they need so that they can thrive. They desperately need red blood cells, and these red blood cells, what they really need is the iron, and they need to be able to sequester the iron found in the red blood cells in terms for purposes of the energy requirements. And this is a specific characteristic, particularly for us in the lab. If we want to make sure we can be able to diagnose properly, we normally use blood agar so that we can see the different colonies growing of streptococci. Another general characteristic that we need to have in the back of our minds, particularly for the lab, when we want to do an appropriate diagnosis, we need to know that they're catalase negative. And I know this afternoon you'll be having a practical where you'll be able to visualize what catalase is. It's an enzyme. And this enzyme is needed by different bacterium to be able to break some oxidative mechanisms which are toxic to them. So catalase is an enzyme that's able to break down the hydrogen peroxide to just hydrogen and to water and oxygen. Again, this is to help them be able to thrive. So they lack this enzyme, but I believe you are able to see this in the staphylococci pathogens. When you are looking at them, they have this enzyme and they're normally catalase positive. So hopefully you'll be able to visualize this. This is a very important test that we normally use to be able to help us differentiate between strep species and the staph species. So how do we classify? We've looked at the general characteristics, but how do we classify streptococci? It's a large family of bacterium or subspecies, and you're going to appreciate that. And there are various explanations given in different books on how to classify them. But the two major classifications are normally one through serology, and this is through the antigen antibody agglutination tests. And this is normally known as the Lancefield classification, again named after this lady, was a microbiologist many years ago, I think a century or two ago, where she was able to differentiate the species through this agglutination technique or serology, and it was later termed as Lancefield classification. And the other way we classify streptococci is through hemolysis, i.e. how they utilize the blood. And remember, I've mentioned they need the blood to be able to sequester iron. And how they do this is through lysing these red blood cells, and how they lyse them and how they grow in the colony subsequently are very distinct patterns. And we normally use that to be able to classify them. I'm going to take you through the classification techniques one by one, but allow me to mention briefly what the serology Lancefield classification is all about. And in the Lancefield classification, I mentioned the streptococci are classified into groups depending on how the C carbohydrate antigen, which is found on the cell wall, agglutinates with commercially available antibodies. And this way, when it agglutinates, it forms different patterns, and these patterns are grouped. We have the major group, which is group A, all the way to group B, group C, group D, and others that are grouped as EU. And we also have other streptococci that do not conform to this serology. So we name them as ungroupable streptococci. So here, again, this Lancefield classification relies on the C carbohydrate to be able to group them into group A. A good example of streptococci that fall under the group A pathogens are streptococci pyogens, and I'm going to take you through what type of infections strep pyogens forms. We also have a major group, group B, and a group B, we have strep agalacti, an important pathogen as well, and I'll take you through why we need to consider this, particularly in pregnancy. Then we have group C, normally seen in animals such as horses, strep equisemistis. I'll not really mention this. This you can read through in literature. I'll mention also group D, enterococci, which also cause significant infections in humans. And I'll also take you through the ungroupable groups, of streptococci and take you through what type of infections it from. So the take-home message for the serology landscape classification, they use this mechanism in serology of antibody antigen agglutination based on the cell wall of these pathogens, and they're grouped between group A to K and H to V, depending on the how it agglutinates, and each has a major subspecies under each group, and I'll be able to take you through them. So let's go to the next way of classification of streptococci, and this is through the hemolysis. And hemolysis, as you can see from the word, is how it lyses blood on a blood agar plate. Very important for me and you who want to be able to do a proper lab diagnosis. And we normally use this blood agar plate, as you can see here. And the way it sequesters the iron, and once it sequesters the iron, some oxidation occurs, and that oxidation brings about a color change on the red blood agar plate. What do I mean? So we have three different types of lysis, and I'll start with the beta hemolysis. And in beta hemolysis, let me start with alphabetically, alpha hemolysis. So I've mentioned it's how it sequesters iron on a blood agar plate. So in alpha hemolytic streptococci, they partially lyse the blood on the blood agar plate. So they don't need to fully lyse the entire cell or the red blood cell. They partially lyse it. As with that, they're able to sequester the iron, but this brings a green discolorization because of the iron oxidation around the colonies that grow. Very important to us in the lab because we are able to be first diagnose this is strep because it's green on a blood agar plate, and then there's a color change around the colonies, meaning it has partially lysed the red blood cells because of the iron oxidation. And I've mentioned why iron is important to them. And an example of subspecies of streptococci that partially lyses the red blood cells is a non-groupable. Remember the Landsfield classification streptococci. And a good example is Strep pneumoniae and Strep viridans, which I'll take you through. The next type of lysis or patterns that we normally see is the beta hemolytic streptococci. And with this, they normally completely lyse the red blood cells to be able to completely sequester the iron from the red blood cells for their energy growth and reproductive capabilities, their nutrients. So in this, if they completely lyse, there'll be colonies growing around in the red blood agar plate. But these colonies, because of the complete hemolysis, you see clear zones where the colonies are growing. So you started off with a red blood or a red agar plate, but where the colonies are growing, you see clear zones because they've been able to completely break down the iron. And the next and last classification of how we group streptococci, depending on the patterns on the blood agar plate, we have the gamma hemolysis. In this type of patterns, this specific streptococci do not need to lyse the red blood cells. They're able to sufficiently grow on the red blood agar plate without sequestering the iron. And here we normally see the red blood agar plate where the colonies are growing. You still see the red color is maintained. And an example, we have the group D Enterococci subspecies, which are. So the take-home message here, let me just take you back here, is the hemolysis on a blood agar plate, which is important for us to be able to do an appropriate diagnosis of what type of streptococci is growing. And we have three classifications: beta, alpha, and gamma. And with the beta hemolysis, remember I've mentioned, it completely lyses the red blood cells. So where the colonies are growing, you see clear zones. So the red color is completely sequestered or dissolved, in other words. For alpha hemolytic streptococci, they just need to partially lyse, so they don't need the entire iron. So because of the oxidization process, when they're sequestering the iron, we see green zones. And I'm hoping that when you're doing your practicals, you'll be able to visualize this quite well. So you see the green zones where the colonies are growing. And for the gamma hemolytic, they don't need to lyse the red blood cells. The colonies will grow quite sufficiently. And what you see is where the colonies are growing, the red color of the red blood agar plate is retained. So we use this technique to be able to classify different Streptococci subspecies, which I'll take you about. So take home message, we've looked at the lung fluid classification. Now we've looked at the hemolytic patterns on a blood agar plate that helps us differentiate between different subspecies of the Streptococci. And in the next few slides, I'll take you through the different subspecies, the type of infections they cause, and how then we use this backbone of classification to be able to do an appropriate lab diagnosis. So I'm hoping there are no questions so far. If there's any, just let me know. Just hold on 1 minute. I can see the principal calling me. Okay, sorry for that. Yeah, there's just some administrative challenges the principal wanted to clarify. So I'm still, hopefully we are still together, and allow me to continue. So in short form, just to bring you to back to basics, we've looked at I've introduced streptococci, the general characteristics, which I really want you to have at the back of your mind. And then we've looked at the different way we classify them. So let's now look at the different major groups under streptococci and the types of infections they form. So I want to start off with beta hemolytic, and just remind you, beta, these pathogens normally completely lyse the red blood cells found in the blood agar plate. Again, very important in terms of diagnosis. And group A is under the Lansfield classification. So when you're doing your revision, looking at textbooks or literature, you find them known as beta hemolytic group A streptococci, or in short, GAS. GAS just standing for group A streptococci. So when you see that, fear not, just stands for the group A streptococci that normally lies the red blood cells in the blood agar plate. And here, I just want you to appreciate, remember, they occur either in pairs or in chains, and you can see that they somehow attracted to red blood cells in this blood sample. And again, you know why? Because of they're attracted to the iron, which they need for their own nutrients requirements. A lot has been published or said about group A streptococci. And this is some of the, just a snapshot of some of the pathogen, some of the headlines reaching the science world or news articles. If you follow me online as well on Twitter, once in a while I tweet about many pathogens, TB, etc., which I'll take you through in a few weeks' time. So here, there's this headline, group A strep could be on its way to antibiotic resistance. You can remember my first two slides where I spoke about antibiotic resistance. There's this other article here, the shock of strep, rapid deaths due to group A streptococci. Again, that's been noted, and it's also in relation with the antibiotic resistance. If we don't treat group A, again, we may start seeing some severe morbidity and mortality. And of course, other news making the headlines is how these mutated strep strains are becoming quite difficult to treat. So let us look at group A, or GAS in more particular. And the major pathogen here is strep pyogenes. And I'm sure you've heard about it. If not, you've had this infection because it's the one that's implicated to cause strep throat, which if you've been had a sore throat once in a while, particularly when you're much younger, more or less this was a strep throat that needed an appropriate way to treat. So let us first look at the virulent factors of the group A, and in particular strep pyogenes. And remember in the back of your mind, the different characteristics, the general characteristics of the streptococci, and in particular the group you're looking at, the cocci, they occur in panes or chairs, what do I mean? They occur in pairs or in chains. They lack the flagella, the non-spore forming. So I just want you to have that in the back of your mind. I also want you to also be cognizant of the fact of virulent factors found in this pathogen, why it needs virulence factors. Again, I've already mentioned to you why this is important. Again, they need to be able to attach, invade, distract, cause any destruction. In this particular case, they need to be able to sequester the ions. They need to be able to lyse. So they need enzymes that assist them to lyse. So these are some of the virulence factors. You find that also in the GAS subspecies, they produce toxins. Again, these toxins just continue to help it to disrupt cellular function, to be able to break down cell junctions so that they can be able to colonize, get the nutrients, and also they cause significant cytokine storms, and this may result to multi-organ failure or untimely death if we do not treat this pathogen in an appropriate way. So some of the virulent factors found in strep A and in particular strep pyogenes. They're all listed here in this diagram, and I'll be able to send you these notes so that you can see, and I'm sure you're also recording. You have the cell membrane, the cell wall, which again helps it invade and evade the immune system. So we have the capsule, which I mentioned. It helps it prevent phagocytosis or the digestion of this pathogen by different cells such as macrophages. So it prevents that. It has a fimbriae, which helps it attach. All these are virulent factors. So if we ask you to explain to us some of the virulent factors, always have in your back of your mind what a virulent factor is, just what factors make it be able to thrive inside the host cell. And I've mentioned the different structure of virulent factors. It has enzymes, which again break down the junctions, which breaks down tissue cells so that it can be able again to colonize. Some of the enzymes are listed here. We also have toxins. Again, it produces exotoxins to be able to deal with the cytokines that the immune system may throw at this pathogen. So all these are virulent factors that help this bacterium fit enough to cause an infection. So when I was researching to see what type of infections it causes, I've already mentioned one of the major infection gas pathogen cause, and in particular here we're looking at strep pyogenes, the major strep in this family. It causes the sore throat and several other infections which I'll take you through. And the population that is at most at risk, you can see this kind of U-shaped graph. It's children under 5 and also the elderly. So really here, we need to be able to treat this infection sufficiently. And for me, the most appropriate way is to have a vaccine for strep pyogenes or group A streptococci that will help prevent these infections in children under 5 and also in the elderly so that they can have reduced morbidity and also mortality caused by these infections. So what type of infections does strep pyogenes cause? Here, it causes a wide array of infection, the major one being the strep throat. And you can see some of the infections are divided into different categories. We have superficial diseases, such as diseases found on the outer skin surface and also on the oral cavities, and also the oral membrane, such as pharyngitis or the sore throat. It can cause some skin changes, such as impetigo. And then when you look at deep infections, it's been implicated to cause bacteremia. It's been implicated to cause necrotizing fasciitis. These are flesh-eating bacterium which feeds on the tissues of the deep, found in the deeper areas of the body. It's also been implicated if it is able to access the CNS, cause meningitis, and several other serious infections. Remember, it also produces toxins. So it has toxin-mediated infections such as toxic shock-like syndrome, scarlatina, etc. And also it can cause immunologically mediated diseases. How does it do that? The body, the immune system responds in terms of once it's under invaded by the strep A, and some of these response antibodies produced normally are autoreactive, i.e. they target other tissues within the body, causing major complications. Some tissues that have been implicated to be destroyed or destroyed, that's a better word, by the antibodies produced against streptococci are tissues found in the heart area and also in the kidney. And again, I'll just take you through this. So in summary of that slide, strep group A or streptococci pyogenes has been implicated to cause the sore throat, different skin infections such as scarlatina, and also more serious hemolytic streptococcal gangrene, or in other words, necrotizing fasciitis, which causes serious tissue damage, because remember, this pathogen normally destroys tissues or destroys different cell junctions so that it can sequester iron and produces toxins, which may also lead to the dissolving of different tissues, causing this quite distinct tissue damage. So let's look at strep throat because it's a very common infection caused by gas. And just as a summary, strep throat, this pathogen is passed through droplet infection. And of course, you're familiar with some of the symptoms such as sore throat, high fever. And when you look under the, when you look at in the throat, you may normally visualize some white drainage pus or some pus at the back of the throat. And here you can take a swab of this pus to be able to do some appropriate lab diagnosis. A lot has been published on strep throat, and why we are very interested in the strep throat, particularly in children, if we don't treat it appropriately, it can cause serious implications. For me and you, who are quite fit, and I'm hoping we're all fit, if we develop that throat complication, we are normally told we can gargle some salty water 2-3 times a day, and it's able to resolve. But for younger children under 5, and also the elderly who are not able to sufficiently clear this infection, the body produces antibodies as it should directed against strep pyogenes. But I've mentioned that these antibodies also may cross-react with some muscles found within the heart and also in the kidney, causing serious complications. And one of the major complications that strep pyogenes may cause, we have the acute rheumatic fever, and I'm sure you've heard of this, and can lead to a lifelong complication within the heart. And also, these antibodies may cross-react to some proteins found around the kidney, causing acute post-streptococcal glomerulonephritis. So it's very crucial for us to be able to do an appropriate diagnosis and then initiate treatment, particularly in children under 5 and all in the elderly, so that we can avoid these major complications. So this is just an explanation what happens if we leave it untreated and the body is not able to sufficiently clear like it should in a healthy adult. The bacterium is spread, and this leads to antibodies being formed, which again leads to serious heart damage because these antibodies cross-react with some of the proteins that have similar patterns to the the pathogen itself. And of course, if we don't treat it appropriately with less effective drugs, we continue to fuel antibiotic resistance, again have this bacterium lingering in the body system, causing antibodies again to be produced, leading to this complication known as rheumatic fever. So we need to be able to do an appropriate diagnosis. So how do you do this? I'll take you through this theoretically, and I believe in the afternoon, you'll be able to do this practical. So you, again, appropriately do take a throat swab or pus swab, or if you suspect your patient has a blood infection, you can collect some blood or CSF, or depending on the symptoms the patient has. Once you have this sample in the lab, we normally do a macroscopic investigation, i.e., what do you see with your naked eye? What's the color of the pus? Is it bloody? Does it have a distinct color? That's important for us to be able to note in the lab book to help us make an appropriate diagnosis. Once you do your macroscopic investigation, the next part is to do a microscopy. So using a microscope and using the appropriate stains, we normally do a gram stain, where again, you'd expect to see gram-positive cocci, again, maybe surrounded by pus cells. And once you do that, you would want to do a culture, an overnight culture. And remember, we do the culture on a blood agar plate, so BA, aerobically, again in our incubators in the lab. And after 18 to 24 hours, you should be able to observe your colonies. Remember, this is a beta hemolytic group A. So what you see in beta hemolysis, we normally see complete lysis. So you'll be able to see clear zones where the colonies are growing. You may want to do a repeat microscopy of the culture, where again you confirm that there are gram-positive cocci occurring in chains. And then you may employ your biochemical test. Remember, the catalase test is important for us to be able to make sure that we are able to differentiate between staph and strep. And remember, the streptococci are catalase negative, And then from there, you can do other tests. So we normally do an antibiotic susceptibility test. We use bacitracin antibiotic, and most gas or most streptococci pyogen pathogens are normally bacitracin sensitive. Please note that down because it helps us make the correct diagnosis and also formulate the correct treatments. So prevention, again, if you suspect you have a sore throat, again, make sure you seek medical advice. You can also do some gargling of some salty water, which again helps in lysing some of these pathogens within the throat, so you get to feel better quickly. And remember, we need to treat sore throats, pharyngitis as early as possible to prevent acute rheumatic fever and other complications. And remember, and unfortunately, we still do not have a vaccine, because I believe we need a vaccine and we need it soon so that we can be able to prevent some of these complications. So again, I came across this poster in some clinic. A sore throat can lead to a broken heart. And I hope now you can relate why this clinic was saying that. It was just trying to raise an awareness. They need to be able to treat the sore throat, these swellings, or treat this bacterium because of the cross-reactive antibodies that may end up damaging some of the heart muscles, causing rheumatic fever. And this was one of the essays I sent, I think, for one of my classes, where I asked the class to explain or take us through why a sore throat, in quotes, can lead to a broken heart. And I really wanted to see that they could relate some of the complications caused by the group A pathogen, that is the streptococci pyogenes. Okay, so allow me to move quickly to the group B streptococci. And in most textbooks, they normally call them GBS. As when you see that acronym, when you're reading streptococci, know that this is group B. Remember, that's the Lansfield classification. And we're going to see that group B streptococci, also, most of them are the type of patterns they form. But once we do a diagnosis, they're normally beta hemolytic colonies. So let me take you through why we need to be able to understand group B streptococci. Group B, first of all, the major pathogen here is Streptococcus agalacti. Yes? Yes?
We can continue.
Oh, okay, I thought someone had a question. Again, if you have any question, please just let me know. So let us look at Streptococci agalacti. So they colonize, or they are normal flora, or part of the microbiome of the GUT tract, so the genitourinary tract, or the lower gastrointestinal tract in most people. And they, just as a recap, they're gram-positive, non-forming, non-motile, and capsulated. And in this electromicrograph, you see that they occur in chains or in pairs, again, conforming to the usual characteristics of streptococci. And why this pathogen is important, sorry, it's the type of infection it causes. So I've mentioned it's found in the lower genitourinary tract. So this pathogen is quite crucial, particularly in women who are giving birth vaginally or through the natural route of delivery. Because if this bacterium is in high numbers within the genitourinary tract, this baby may be exposed to Streptococcus agalacti, which then may cause some serious complications, such as neonatal sepsis, and neonatal meningitis, or neonatal pneumonia. And this normally have an early onset on the first 7 days of its life, which is particularly distressing for this baby. So it's very important for any woman who is undergoing antenatal clinics to be able, the doctor needs to be able to, or the clinic that is looking after this woman, be able to do a culture and just make sure that by the time of delivery, so at around week 30 to 34, they are able to treat any Streptococcus agalacti. So they would normally advocate for a swab just before delivery. If it's in high quantities, they're able to administer appropriate antibiotics or treatment to prevent this baby having this infection. So this is a vertical transmission in utero or time of delivery if no appropriate actions are taken in good time. Unfortunately, this is not a practice that is done routinely in our setting, but I'm hoping that you'll be one of the people that will advocate that this should be very important, or one of the packages, one of the tests done in any antenatal clinic, so that we can reduce the amount or the numbers of neonatal sepsis or neonatal complications in a baby in the first 7 days of its life. So this is something that we need to be aware of. So how do we do this diagnosis? Again, you can do a vaginal swab or vaginal smear. Again, here I've just given you on how we do that. But also, if we suspect the baby has had this exposure, you can take a CSF, you suspect neonatal meningitis, or take some blood sample to be able to make the correct diagnosis. Also in women, if you're trying to make sure that normal birth delivery is safe, again, you can do this vaginal smear or swab or take the urine sample. Again, before microscopy, do macroscopy, and here would advocate for gram-positive gram stain, where you get your gram-positive chains growing in, or gram-positive colonies growing in chains. For culture, always remember we use the blood agar plate, and these are beta hemolytic colonies, so you see clear zones where the colonies are growing. So here are the clear zones. Again, hopefully, once you do your practical, this will be quite obvious. And following from that, we normally employ a biochemical test. And the biochemical test here that we normally employ would do the catalase to help us differentiate between strep and staph. And then we could employ any of these biochemical tests. Crucial test here is the bacitracin antibiotic. Remember, with the other beta hemolytic that we've looked at, step pyogenes, it's bacitracin sensitive. But for group B or GBS, they're normally bacitracin resistant, and that helps us differentiate between the two group B, between the beta hemolytic streptococci, in that the GBS is resistant to bacitracin. So this is bacitracin disc, and you can see that it's resistant, so it's growing around the antibiotic. Well, for the other one that we've already covered, that is streptogenes normally sensitive, and you normally see clear zones, meaning it cannot grow near the antibiotic because it's susceptible to it. So this is an important test to have in the laboratory if you're making a diagnosis for strep galacti, which is normally bacitracin resistant, and also if you're making a diagnosis for strep pyogenes. So you can also employ other tests or other antibiotics such as penicillin and also CAM test, which can also help us make a proper diagnosis. So here I just want to drum support that GBS is an important pathogen. I know we don't really consider it here in our sub-Saharan setting, but it's something we need to be quite cognizant about because of this vertical transmission. In the Western world, I pulled this from the UK, where they even have an International GBS Awareness Month, that is in July, where they drum up support that GBS is an important pathogen because of the different complication it causes in babies. So mothers, antenatal clinics need to be cognizant of this pathogen and be able to treat it early enough, be able to even have tests to do it, to avoid this vertical transmission and also horizontal transmission when the baby, in the first few days of the baby's life, the baby is hospitalized and is under this care in the hospital. So hopefully we'll be able to raise awareness of GBS. We have a student, a postgraduate student who also did the study. We looked at antenatal clinic in Kenyatta. We wanted to see the courage or how many women present with group B when they're coming for antenatal care, and we're hoping that this work can raise awareness also in our setting. I can see also in Ethiopia, there's a study that came out last year, where they're also showing that there's an associated risk if we don't consider Streptococcus galacti diagnosis before the delivery. So it needs to we need to have maternal education, also have ANC visits that incorporate GBS or Streptococci galacti diagnosis. So let us move on to the next the pneumococci or the next streptococci group. And here now we've looked at beta hemolytic. I want us to look at the major examples of the alpha hemolytic pathogens. Alpha are the ones that partially lyse the red blood cells in the red blood agar plate. And a good major example for alpha hemolytic streptococci is the Streptococcus pneumoniae. You've heard about this pathogen over and over again because of its associated risk. It's been implicated in causing significant infections, again, in children under 5 and also in the elderly. So we really need to pay attention to this pathogen. And the good news is now we have vaccines that help us treat this, prevent this infection in children. And also this vaccine is also offered in adults over 60, particularly in the Western world. And I hope that it will also catch up in the sub-Saharan setting. So let us look at Streptococci in more detail. Streptococci pneumoniae, again, occurs in chains or in pairs as any other Streptococci. It has several virulent factors, such as the cell wall, cell membrane, which contain the capsule. It also produces different lyses or lysins that helps it lyse the red blood cells and any other tissues that it can be able to colonize sufficiently. It has different proteins, different enzymes that again propagate it or increase its own virulency. So let us look at some general characteristics of the pneumococcus or the streptococci. And you notice when you're doing your revision or looking at literature, they normally interchange this word. Some books will call it Streptococcus pneumoniae, others will call it the pneumococcus, I guess because it's such a long word or mouthful, Streptococcus pneumoniae, to keep referring to it. So you see most books calling it the pneumococcus. It has over 100 serotypes. What does that mean? The cell wall has different, can I call them mutations, or the way it agglutinates. It agglutinates in different types or different ways. And of 100 serotypes have been typed using serology under the pneumococcus. And out of this 100, 21 have been implicated to cause infection in humans. So we really need to pay close attention to these 21 serotypes of the pneumococcus, and this is the different ways the cell wall or the outer cell membrane of the pneumococcus is arranged and how it's detected in the lab. It's a normal flora that colonizes the upper respiratory tract right from birth in children. If you do an esophageal swab, you'll be able to notice or be able to culture some of this pneumococcus or the streptococci and pneumoniae pathogen. And again, just remember it's gram-positive, occurs in chains or in pairs. But I just want to highlight that as I mentioned, it's a cocci. The cocci of the pneumococcus is normally slightly elongated, as you can see here. It looks, some textbooks say the cocci has a flame-shaped or looks like a surgeon's knife, so a lanceolate appearance. And this is very key for us who want to be able to diagnose it under the microscope. So it does not just look like your normal cocci, so the nice circular shape, but the circular shape is elongated to look more like a flame or a surgeon's knife or elongated cocci with a broad end and another pointed edge, like as you can see in this electron micrograph. Very key for us because it helps us make an appropriate diagnosis. Here, I'm just again overemphasizing the different virulent factors found within the pneumococcus, again, which helps it colonize, it helps it thrive and evade the immune system or the mechanisms the host will mount against it. One of them, as I keep mentioning, is the capsular polysaccharide. And the reason I keep drumming this relevancy, I see students struggling with this question in exams or in their parts, when we ask them, discuss the different virulent factors of the pneumococcus or whatever pathogen you've been asked for. I just want you to know what these factors are, how they help the pathogen, and then now you can name them. And most pathogens will have a capsule. So I don't want to mark any of you zero when we ask you that. Most pathogens will have a capsule. The capsule helps you to be antiphagocytotic, so prevents macrophages or neutrophils from digesting it, as this cartoon is depicting. It has different enzymes. One of the major enzymes in the pneumococcus, the IgA protease, which helps it break down the IgA antibody, which again, that is found in the mucosal membranes with antibodies. Again, you know the importance of them. So this pathogen has evolved to have an enzyme that breaks down these antibodies. It has different lysins. Again, these lysine enzymes and proteins helps it break down different cells, tissues, so that it can either sequester iron or be able to attach its fibri so that it can continue to spread from one cell type to another into the bloodstream. Again, I'll send you this diagram that just shows some of these virulent factors, how they help, either it's to degrade the mucus, so as it goes through the respiratory tract, or reduce the cilia. The cilia is the innate type of immune system, or the hairs that line up also the nasal cavity that helps trap germs. So it's able to reduce the cilia from trapping it and uses different lysins that it can be able, again, to spread within the host, colonize and cause the different infections. So what type of infections do the pneumococcus cause? I know we all are cognizant of the pneumonia that has been implicated, but again, I just wanted to appreciate it causes both upper respiratory tract infections and also lower respiratory tract infections. And from the upper ones, infections such as sinusitis, that's an inflammation of the sinus, otitis media, that's middle ear infection, meningitis as well, and also invasive diseases such as pneumonia, septicemia, and several other infections have been implicated caused by the pneumococcus. So I really also want to emphasize, yes, it's one of the most lethal bacterial pathogens, because you can see the amount of infections it causes. These infections could cause quite serious morbidity and mortality, particularly in children. But ever since we introduced the pneumococcal vaccine, I think it was first introduced in Kenya in the year 2009, 2010, we have seen significant reduction of these infections caused by the pneumococcus in our population. And I really, really want to drum up that that success story caused by by a vaccine. Okay, my slides are stuck. Okay, oops. So with this type of infections, how do we then make an appropriate diagnosis? Because we need to be able to manage our patient. And how do we manage your patient? We need to be able to note the symptoms, then collect the correct specimens. So here the specimen, depending on the symptoms your patient has, you can collect the CSF, that's cerebral fluids. You can collect blood. You can get the sputum, pus. You can do a bronchoscopy just to make sure we have the correct specimen. Again, do a macroscopic investigation before you proceed to do your microscopy. And for your microscopy, you'll start off with a gram stain. And with a gram stain, you'll be able to spot your gram-positive cocci. But remember, our cocci here is not your spherical ones, or there's proper circular ones. They'll have an elongated spherical shape or lanceolate shape. So please note that down. And then proceed on to do your culture. But then you should have started suspecting is a pneumococcal pathogen. And when you do your blood agar plate, blood agar culture, you should be able 18 to 24 hours later, observe alpha hemolytic colonies. And remember, alpha hemolysis is where you see partial lysis of the red blood cells caused by the pathogen itself, as it sequesters iron. And how do you do your identification? Again, you must do your catalase test to be able to differentiate between the different staph and strep species. 2, you need to do Streptococci and pneumoniae specific identification tests. One of them, we normally use optochin disc, is an antibiotic that is most sensitive, or the Streptococci pneumoniae is quite sensitive to this antibiotic. We also you can also use the bile solution. And in this bile solution, chemical solution, Streptococci is normally lysed by the bile. So what you normally see is that once you introduce your species here, it's lysed, so your liquid becomes clear, while any other Streptococci pathogen it's not lysed by bile. So you see this cloudy appearance. Again, note that down because you need to be able to differentiate it with other streptococcal pathogens. And also you can do the quelling reaction. And in this quelling reaction, it's where the pathogen, we introduce some dye, and at this point, it's normally the methylene blue dye. And you normally see the capsule swelling under the microscope. And the pneumococci is quite particular with this. The capsule of the pneumococci is where you're normally able to see the capsular swelling once you do the quelling reaction test. So this should be in the back of your mind, the optochin disc, where it's sensitive to optochin antibiotic, the bile solution, and the quelling reaction. Again, we normally ask you this in MCQs, in exams, how do you differentiate between strep pneumoniae, let's say strep agalactiae that we've covered so far, or strep pyogenes, and I expect you to list from the way it looks like. One is lanceolate shaped, the other one is circular, and the different biochemical tests that we do. These are all the things that want to see so that I can assess your understanding of this topic. And once you do your appropriate test, you should be able to administer the appropriate treatment. Again, be cognizant of the fact that there's a rising antibiotic resistance. So you need to be able to adhere to the hospital, the clinic setting antibiogram, which then they should have given you guidelines on how to appropriately administer the antibiotic. And prevention and control, thank goodness we have a vaccine, and the vaccine is quite effective. What we have in Kenya, we have this the pneumococcal vaccine that is serotype dependent. Again, I mentioned there are 21 serotypes that have been implicated to cause disease. And in the vaccines, we have the vaccine has like this particular one. I took it to the clinic where my child was getting vaccinated. You can see it's called Prevnar 13. Again, the number means it has the 13 most disease-causing serotypes, and which confer protection to the child and also to the elderly who are given this this vaccine, and this is the schedule that is recommended. So again, I just want to emphasize this vaccine. There's a lot of also newer vaccines coming up that are not even serotype dependent, because remember, serotypes keep changing. We have over 100, and yes, we are 21 disease causing, but there may be other serotypes that may arise in the future that may cause disease. So they're looking at other structures of the pneumococci that they can use to formulate even newer vaccines. Okay, I'm moving on, and I'm almost at the end of the lecture, so bear with me. I'm still at the alpha hemolytic, and allow me to mention the viridans streptococci. Again, alpha hemolytic, and these ones have been implicated to cause the majority of the dental caries or dental decay that most of our dentists in the room will encounter in their careers. Again, the viridans family is a microbial monomoflora of the throat and also the oral cavity. And when it gets its color, it's the green. And again, this green discolorization because of alpha hemolytic characteristics, where you see green colonies, it got its name from. And the species under the viridans family of quite important interest, in case you're looking at the oral cavity, we have different subspecies such as Strep mitis, Strep mutans, Strep salivarius, and Strep sanguis. Again, all these are the subspecies under the viridans streptococci. And how do they get introduced into the, again, they're normal flora, but if you don't have good dental hygiene, they feed off of the on the sugars. So if you have a sweet tooth, I have a really bad sweet tooth. So you have to really take extra care that so that you don't have these numbers of the viridans family growing and causing these complications, i.e. dental caries, dental decay, and also gum disease. So these are some of the implications that I've mentioned, such as gingivitis, gum disease. They can also cause other infections if they stream through the bloodstream. In case you're having a dental procedure, dental surgery, you're normally prescribed with prophylaxis to prevent them seeping through the bloodstream, causing other off-site infections, such as acute bacterial endocarditis, abscesses that have been shown to even occur in the brain and also in the abdomen. And there's a paper that was also implicating some of these oral bacterium that have been isolated in the cerebral fluids, again, having such a similar route of transmission. So how do you do an appropriate lab diagnosis? Again, you can do a swab of that or collect the pus or where the rot is. You can take a swab of that, or you can take some blood if you suspect some bloodstream infection. And once you do that, you do your macroscopy, then microscopy, and you'd expect to see your gram-positive cocci. Remember now, even though it's alpha hemolytic, you're back to your circular cocci. And when you do your culture on a blood agar plate, you see this type of colonies where there's some green discolorization, again caused by the partial lysis and the ion oxidization as sequesters this iron. And then you proceed to do your biochemical test for all streptococci, or most of all the gram cocci. You normally employ a catalyst test and then do your other test. Here we normally employ the optochin. Optochin, again, remember, it's an antibiotic disc, and most viridans are optochin resistant. Where remember, strep pneumoniae is always optochin sensitive. And then the viridans is bile insoluble, so it will not dissolve in bile solution. And in strep pneumoniae, we saw that the bile salts are able to penetrate through the cell membranes of the strep pneumoniae and are able to lyse them so that it becomes soluble. So that's something I need you to note in the back of your mind. And not forgetting, for all these pneumococci, all these pathogens, we normally also employ molecular tests, molecular tools, which are most of the time 99.9% accurate, quite straightforward and very quick, but also very expensive. So you not find them in a routine lab that is making this diagnosis. So treatment for the viridans, recommended treatments, we have the prophylaxis. If patients at risk, they're normally given this prophylaxis before dental surgery and maybe after. And then using your own hospital antibiogram, you can prescribe the antibiotic listed. Last but not least, allow me to mention Group D. Remember, if you've been following me, we've looked at Group A, gas. We've looked at GBS, that's an example of Streptococcus agalacti. We then looked at the non-groupable, and the major groups here, the pneumococcus and the viridans. And now we're in the Group D. And under the Group D, we have the enterococcuses. And in the Group D, this is where we find the gamma hemolytic pattern. Remember gamma, we mentioned that in the gamma hemolytic, they do not lyse the red blood cells in the red blood agar plate. So you'll see your colon is growing, but the color it remains. And then for Group D streptococci, who are gamma hemolytic, as I've mentioned, the major species here, and I just want you to send you some notes. The main species are Enterococci facialis and Enterococci facium. These are the two important species under the Enterococcus or Group D streptococci. Normal flora, or they're found within the microbiome in the gastrointestinal tract or the lower genital tract. And most of the time, they normally cause either an opportunistic infection or an nosocomial infection when we're immunocompromised, and they have been implicated to cause UTIs. They can also form wound infections and also endocarditis. So they need to be treated once diagnosed. And again, there's a rising antibiotic resistance. So you really need, if you're treating enterococci, we need to adhere to the antibiogram prescribed within your hospital setting so that we can be able to appropriately treat them. So in conclusions, points to remember. I know I've been speaking for quite a long period of time now. I think now I know most of us are now cognizant and aware of the general characteristics. Remember, these general characteristics also help us note some of the symptoms, but most importantly, help us in the diagnosis. So the cocci, some are lanceolate shaped, the catalase, the capsule itself, they all assist this pathogen and also us in the lab to help make the appropriate diagnosis. I'm now confident that you can explain or walk us through the different hemolytic patterns, which again, you should be able to appreciate when you're doing the practicum of the different, remember the alpha, beta, and the gamma hemolytic patterns and what that means. We've looked at different major infections. We've looked at the pyogenes. We've looked at the galacti, which is important, especially for the newborn. We've looked at strep pneumoniae, that causes major infections such as pneumonia. We've looked at strep viridans, important for the dentist in our group, and also for general oral hygiene and of oral diseases. We've looked at the different microscopy and colony morphologies, and also the different tests that we employ. I want you to just have in the back of your minds, we are in the era of emerging resistant strains. Even as you're prescribing treatment, you should be able to be aware which first, second, third generation of antibiotics that you can use. But the key thing here is to have vaccines, because I believe with vaccines we'll be able to prevent and eradicate eventually some of these infections. And in terms of development of these vaccines and discoveries, I just want to highlight, yes, for the pneumococci, we have a vaccine in use, and it's been quite successful. And there are several more vaccines coming in place so that we don't have to be dependent on serotypes because of this phenomenon of vaccine escape, which I've tried to explain. For pyogenes, there is vaccine, thank goodness, in development. So I believe maybe in the next 5-10 years, we'll have a vaccine that finally help us get ahead of strep throat and most importantly, avoid these complications, the ones I mentioned, rheumatic fevers and kidney complications. So this was in development. And also, thank goodness, we also have a galactide vaccine in development. And it's the idea is to administer it in pregnancy to prevent these complications that we've noted in newborns. So again, I end my lecture there. Any questions, comments? Welcome now. Any questions, comments? I'm looking, so I can see questions in the group. Sorry, I was not seeing the chat because I was on presentation mode. I can see several. So how do mothers get Streptococci agalacti? Remember, I mentioned they are part of the normal flora of the lower genital urinary tract and also in the gastrointestinal tract. There are factors which we are trying to understand in the lab and scientists are trying to understand why some women have more counts or more of this bacterial load of agalacti more than others. Could be genetics, could be diet, could be several other factors we are trying to understand. Because if we understand them, we can be able to reduce the bacterial load that these women may have and hence have a successful outcome of the delivery and also of the neonate. So that is something still under research, but it's normally a normal flora that is found in mostly in the lower intestinal tract and the genitourinary tract. So let me look for more questions. I saw someone asking, please go slower. Hopefully I was slow enough. If not, you can have the recording where you can rewind and pause and take notes again and again. Sorry if I was a bit too fast. Let me see, a lot of names. Okay, still scrolling up and down to look for questions. Scrolling, I'm still here. Scrolling up and down. How do mothers elaborate? Okay, you can see 2 questions. How do you determine drug resistance in a clinical setting? So I've mentioned each hospital, like now, let me use KNH. Normally, if you're the prescribing pharmacist or physician, each hospital normally has an antibiogram where they sit and they test. So really, just to explain it simply, they test the different pathogens depending on the antibiotics available, and they note, they can do the cultures themselves or use specialized equipment, such as there's specialized equipment in KNH that does the molecular testing, so tapes and finds if this pathogen is resistant to a different array of first, second, and third generation antibiotics. And then once they use this, like such as the Mauditov, so there are several of them that are found within for example, the Kenyatta National Hospital that guides the drawing up of the antibiogram that then dictates which hospital or which clinical setting, depending on your setting, what antibiotics can be prescribed depending on the pathogen that you have diagnosed. So please explain how in antibiotic identification test, i.e. sensitive and resistance on the blood is explained. So for example, let me use the pneumococci. For the pneumococci, for identification specifically, we normally use the optogen disc. This is used in the lab to help us know if it's resistant or sensitive. So in terms of, let's say you have a specimen, you've cultured it, and you notice that it's alpha hemolytic, i.e. you notice that it has green colonies. So 2, the next thing you'd want to do is to differentiate if this itself is the pneumococci or the viridans. Remember, at that point, they're all gram-positive. They have that green discolorization. So if you place in your cultures, as you're culturing this pathogen, if you place in the optogen disc, so what you do now in a clinical setting or a lab setting, you'll set up several of these plates, put in your bacitracin, put in your optogen, and put in some of these antibiotic tests that we normally use. So in this case, when you put your optogen, you see the green colonies, but you notice that if it's Streptococci pneumoniae, because it's sensitive to the optogen, it will not grow around the antibiotic because it's sensitive to it, it's susceptible to it, the antibiotic stops its growth. So you see that where the optogen disc is, you see around that disc, there'll be no growth. If it's a viridans on the other hand is resistant to optogen, so it will not be able to cause any it will be able to grow around that disc because that antibiotic has no effect on it. So it's optogen resistant, and for us, we'll use it to be able then to differentiate between 2 similar pathogens. So that's the idea between sensitivity and resistance. And then when you do your antibiotic and chemotherapy lecture, you'll be able then to even look at how we measure. So we take where that resistance is, we take a measurement between the disc and where the colony is, and we'll be able to come up with a mean inhibitory concentration that is needed to stop the growth of this pathogen. So there's a lot of calculation that is done, but simply we look at if there's a colony growing around the antibiotic or no colony growing around the antibiotic. Okay. So Ondit is asking, are there other pathogens that cause pneumonia other than S. pneumoniae bacteria? Yes, so pneumonia is that inflammation and that inflammation around the lungs, alveoli, where either they fill up with water. So So that's a general form. And pneumococci, strep pneumoniae, is one of the many that causes pneumonia. You'll see that also when you look at viruses, for example, we have viral pneumonia. We also have fungal pneumonia. You've seen even COVID also causes pneumonia. So that's an implication, but one of the major pathogens under the bacterial umbrella that causes pneumonia is strep pneumoniae, and also Haemophilus influenzae, which you're going to cover when you're looking at the Haemophilus lecture. And the good news is now we have a vaccine against Haemophilus and also a vaccine against strep pneumoniae. So that's good news because you're seeing a reduction of the burden of infections caused by these two bacteria that had really caused high morbidity and mortality rates in our children. But remember, we still have viral pneumonias still circulating, and there's vaccines, viral vaccines that have been formulated. We have the COVID vaccine now that also is dealing with some types of viral pneumonias, and hopefully we'll be able to treat pneumonia using vaccines or prevent pneumonia against using vaccines. So without any other further question, for some of the tests that I've mentioned, the biosolubility, the antibiotic resistancy, how we measure that, the Qualling reaction, bacitracin, and also looking at the hemolytic patterns, you'll be able to do that in your practicum. And also for today, your practical start at 2. Please be in the lab at 2 p.m. And also, I know it's noon, but there's Miss Odera would want, please do not leave. Miss Odera wants to enter the Zoom meeting so that she can quickly take you through her lecture, to give you enough time in the lab, because we want you to really have hands-on experience with this pathogen. So thank you very much, and wishing you a good afternoon. Asante.